Good evening, LBK.
Good evening, ma'am. Good evening. Somebody sharing the slides.
Yeah, Harish is doing it.
Yeah.
Bhargav, you're in? Bhargav?
Yes, ma'am.
Okay, good. Bhargav, and who are the other
Yes,
two?
ma'am.
Who are the other two?
Ma'am, Dr. Binila and Dr. Deepak, ma'am.
Okay, they all the three can come on. Yeah, good. Okay, we can start. Yeah. VT has joined. VT,
Here, discussion. Case discussion.
VT, you're there?
No, ma'am.
Okay, we start. I think you'll join. Right? Start off.
Yes, ma'am.
Yeah,
So
Bhargav.
here is a 52-year-old male patient who presented with yellowish discoloration of eyes and urine for past 1 month, gradually progressive, not associated with itching or clay-colored stools. He took alternative medications for 10 days. Noticed worsening of yellowish discoloration of eyes and urine. Also noticed mild abdominal distension for 5 days.
Any other history?
Sir, any associated abdominal pain or fever with the jaundice?
No, there was no prodromal symptoms.
Ah.
So he found there was a yellow discoloration of urine eyes for one that became gradually progressive. Initially, he did not have any abdominal distension. He did
After
not.
the intake of CAM, he developed abdominal
After he
distension.
took alternative medicine for 10 days, he found that his bilirubin is noticed worsening of yellowish discoloration of eyes and urine. And
Yes,
also
sir.
noticed a mild abdominal distension.
Yes,
There
sir.
was no pedal edema. So there was no prodromal onset, but it
Yes,
was
sir.
an yellowish discoloration of urine and eyes. And gradually progressed.
Any intake of alcohol prior to the onset of jaundice?
Yeah, he's been consuming alcohol. He has got alcohol use disorder.
Yes,
And, so we'll come to that a little later. Anything else you want on this? So basically here he has got a 1 month history of progressive jaundice. He went to a local doctor. He was told to have jaundice and then he switched down to camp for 10 days. Then he found that there was yellow discoloration, also mild abdomen for 5 days. That is roughly 4 weeks after the presenting of the jaundice. After camp, he has got a mild increasing abdominal distension.
yes, sir.
So what do you think at this point of time you'll think?
What are the other any other questions you'd like to ask, Bhargav?
Ask
That's
here.
good.
before we go to.
Sir, I would like to ask any associated abdominal pain with abdominal distension.
No, there was no abdominal pain. There was no fever.
Yes.
Any other? With decompensation, what are the other questions that you'd ask?
Pedal edema, I would ask. Urine output,
There was
I
no
would ask.
pedal edema. Actually, he said there was no pedal edema.
What else?
Urine output, I would ask.
He
Was
says
there
he
any-
maintained the urine output till he took this scan.
Yes.
And after that, along with the abdominal distension, there was a mild decrease in the urine output.
Yes, sir.
What are the
Any
questions
history
you'll
of-
ask for the complications?
Any
Yeah.
history of
Anything else? Any other history you'll ask?
hematemesis melena?
Yeah. Any history of GI bleed? He did not have any bleed. Either he didn't have hematemesis or melena.
Yes, sir. Any altered sleep pattern?
There was no history of any altered sensorium or sleep pattern. Correct. I think you are more or less completed.
Any other question, Bhargav, along with abdominal distension?
Abdominal discomfort, we have mentioned, no?
Yeah, what else? The
I would like
lungs,
to ask about his appetite. Any weight
lungs,
loss?
lungs.
Breathlessness, I would ask.
Anorexia was there. He was not able to take much food. There was no vomiting.
Yes, sir.
There was anorexia.
Yes, sir.
And there was no history of any breathlessness or any other symptoms like cough or anything.
Yes, sir.
So what do you think he has? Somebody has got a yellowish discoloration of eyes going on for 1 month, has a cam and has got a mild decompensation of following cam.
What are the
Sir,
possibilities?
Sir, this looks like a non-cholestatic jaundice, which was insidious in onset and progressing for almost 1 month. So, any acute hepatitis can be a possibility, or underlying chronic liver disease also can be a possibility. With
What you said, this
which-
could be an acute hepatitis.
yes, sir.
One, it could be acute hepatitis. Number two,
It could be underlying chronic liver disease.
it could be a chronic liver disease
Yes,
with
sir.
decompensation.
Yes, sir.
Okay. You think this is a natural history of decompensated cirrhosis or this anything, any other entity?
Sir, decompensation can be due to alternative system of medication.
So what do you think this is a natural history of decompensation or you have any other this one? I'm just asking you whether you think he has got underlying liver disease and he is just naturally decompensated, or you think he has got something like an acute on chronic liver failure.
Presentation looks more of acute on chronic liver failure
More looks
because
more like-
duration of decompensation was very less, very short.
Now the point
Immediately
is
after
that the worsening yellowish discoloration of eyes and urine after taking a CAM. We don't know biochemically what has happened, but at least till he took the CAM, historically he was not decompensated. He had no progressive jaundice. In fact, his bilirubin was 1 when he first saw, but later when he went and took the CAM and he started developing abdominal distension outside the bilirubin was 33 milligrams.
yes,
So here is a patient who progressive jaundice, clinically a decompensator after a CAM, but does not have history of GI bleed, does not have any history of altered sensorium.
yes, sir.
Okay, and we are not very sure of the oliguria. So it looks as if that he might have.
Bhargav, what are the other questions that you would ask in this patient for the performance score? Treatment history, performance score, you'd like to know as you're progressing with the history, as component of the history?
Performance status to be asked to this patient. How is his day-to-day daily activities after the onset of jaundice?
Basically, what happened is after this, when you go to the next slide, he came to us. Can we go to the next slide? Because he developed severe loose stools. So he had 8 episodes of, he had a food insight, and then he came to us with 8 episodes of watery to small volume mixed type of stools, no blood or mucus, no tenesmus. So he had sometimes watery thing. That's exactly brought us here. So when he took a cam and mild autonomic, when he took food, he went had a acute onset of diarrhea, and at that point of time, when they checked, his bilirubin was 33. So he came to us like this. Okay.
Yes, sir.
Now, the diarrhea in this patient could be related to that. Can it be unrelated to the food he's taken? The person is consuming alcohol.
This diarrhea can be liver related or unrelated.
Always keep that in mind. No? Alcohol use disorder, diarrhea, but it's short duration, 3 days. But just keep that in mind. Maybe this is a start of the problem. No? It may be just a part of the suppressed state. Maybe this is the beginning. Just keep that in mind so that you ask for your high risk behavior and all later. Related to most probably the food taken. So you ask for history of vomiting, ask for history of painless diarrhea, watering diarrhea. So as also already said, did he require IV fluids? The question will just go to osmotic, is it secretory? Some questions like that will just drop in here. Okay. Okay. You can move on.
Go on the next slide.
There is no history of fever, GI bleed, no history of loss of appetite, no history of breathlessness, chest pain, palpitations, prior surgeries, blood transfusion, high risk behavior.
What is the impact of say any surgery on a cirrhotic liver?
Sir, in a cirrhotic patient, mostly it will be ischemic liver injury that is going to be
No,
precipitated.
the most important statement you need to say is that any type of surgery in even a well compensated cirrhotic, post-operatively you can get into a decompensation or you can get into ACLF.
Yes.
So important thing. So that is what we think. So any surgery. So it's important when patient has come to you with ACLF, I think apart from having an infection or something, you need to look for a surgery. Patient would have had a small circumcision, would have had even a hernia repair, but still they can always decompensate. So any type of surgery in a cirrhotic patient will always,
Yes.
and this is very, very common in patients with which type of cirrhotics. They generally come with the first onset of ACLF. You think it's Hep C, Hep B, NASH, alcohol, which one?
Hepatitis B, sir.
NASH related. Always remember that NASH related patients will keep on going with asymptomatic cirrhosis for quite some time. Okay. So the moment you see patients with NASH, and if you find that the platelets are dropping, even though they are well compensated, you need to be very, very careful that they are becoming cirrhotics. So the first presentation of these NASH cirrhotics could be with an ACLF following some other intervention. Till such time, they'll always be there. And you should always, they might ask you, since you're going for the exam, you should know how do you stratify the risk of any extrahepatic surgery in a patient with cirrhotic.
Bhargav, we have come across patients undergoing umbilical hernia repair. Surgeons are very scared of it.
That one consultation is cirrhotic. He has come with a strangulated.
Yeah, cholecystectomy. They don't want to touch patients with cholecystectomy. They will not do any major surgery. They're always worried that they will have. You've seen yourself, no? They're going for decompensation. We had autoimmune hepatitis when she went in for liver cell failure. Then umbilical hernia, we had problem in managing it in the post-operative period. So there are those marginal livers.
So that is
CTPA, where they just said it. Yeah.
So you have. So you need to stratify with that. Kindly look through Mayo Clinic score and Ocal Pen score. Mayo Clinic score and Ocal Pen score to stratify the risk. The risk will be anywhere between 10 to 30%, including mortality. Okay, that is something which they might ask you, how do you stratify? It's very, very common with a decompensator to come with a strangulated hernia and as madam said, incarcerated umbilical hernia. And when you are post-operative,
Vanilla, you have two connections. Stop one.
Okay, ma'am.
So you need to stratify that. That's why sometimes the first onset of decompensation can be with a surgery. That's why there's any prior surgeries or first of high risk behavior. This is
Yeah.
just a point I want to tell you before you go for the. Okay.
Yes, sir.
Yeah.
Past history,
Yeah.
systemic hypertension, not on any regular medication.
He's not a diabetic or something.
Yes, sir. Any previous history of similar complaints?
No. This is the first presentation. No. He has never had any jaundice or anything earlier. Okay.
Yes.
He has not received blood. There was no surgery, no blood transfusion.
Yes. Personal history, chronic ethanol use for past 10 years. Initially used to drink 120 ml brandy thrice a week. For last 3 years, patient takes 180 ml brandy every day. Last intake was 25 days back. Not a smoker, normal appetite.
That's what he says, but for the last 25 days, he was not eating well after
Yes,
taking of this thing, and he had weight loss, but there was no normal bladder and bladder habits.
yes, sir.
So what's the quantity of alcohol?
This looks like significant alcohol consumption.
What, how many grams? No, calculate and tell, no?
180 ml is 60 grams per day.
60
Yeah,
grams per
50
day.
grams per day for
Oh.
past 3 years, and there was around
So kindly
50
look all
to
the
40.
definitions of this. When somebody gives you this sort of this one calculation of your how much of thing of grams, it generally roughly will be 180 ml by 3 will be 60 grams per day. Look the definition of alcohol use disorder. Okay.
Yes,
And what is complicated, what is uncomplicated withdrawal, and always cage questionnaire and C audit both have to be included in this. And
yes,
how much one drink means, what is binge drinking for male, what is binge drinking for female.
yes,
5 drinks and three to 4 drinks in female. Okay. So kindly know all these things.
yes, sir.
Somebody comes from the north, they might even ask you what is the per capita consumption in India, each state. Okay.
Yes,
Punjab has got the highest, followed
Highest.
by Andhra Pradesh. People say by Kerala, but Kerala
Kerala.
doesn't come in the first two,
Yeah.
or third or fourth.
Andhra Pradesh, I think.
Per
Kerala.
capita, let's look through the per capita consumption in the Indian population in some of these states. Okay.
yes,
Bhargav.
yes, sir.
Okay. So can you just quickly summarize this patient?
Yes, sir.
This case is more of a management issue, so kindly summarize this patient.
So here is a 52-year-old male, hypertensive, not on any medication, with no other comorbidities, presenting with progressive non-cholestatic jaundice for past 1 month with no prior prodromal symptoms or binge alcohol consumption, uh, followed by which he took alternative system of medication for 10 days and later decompensated in the form of ascites. There were no any GI bleed manifestations and no altered sensory.
So there was no GI, any history of GI bleed or encephalopathy. Okay.
With his performance status being normal.
Okay.
Yes.
So this is a typical case which will come to OPD. Okay. So what will be your differential diagnosis in this case?
Sir, differential, I would like to keep.
There was no fever.
Yes, sir. My syndromic diagnosis will be
Yeah.
either
No, syndrome number 1. Number 2.
jaundice.
Yeah, your syndromic diagnosis will be what? How it will be a diagnosis? So somebody who's been having a significant alcohol intake for more than 10 years comes to you with progressive jaundice, CAM followed by decompensation followed a CAM. He has no encephalopathy. He has no GI bleed.
Yes, sir. Sir, I'll consider chronic liver disease with
So
etiology.
first, I want to think of chronic liver disease due to alcohol.
Yes, sir.
So that means you think it's a cirrhosis or?
Cirrhosis of liver,
Okay, cirrhosis followed by?
followed by drug-induced liver injury,
No. He's got cirrhosis.
Yes,
You think this is a decompensated cirrhosis or you think this is an ACLF?
sir. I think it's an ACLF.
I think this is an ACLF. Okay.
Yes.
So ACLF triggered by?
Triggered by drug-induced liver injury in the form of alternative system of
Drug is only for 10 days. If you look at the canonic study,
Yes, sir.
which are the two things which are the two common trigger points in an ACLF in canonic study?
Infection.
Alcohol and infection.
Yes.
Alcohol and infection. So I think the first thing will be probably an alcoholic hepatitis on a pre-existing liver disease. Could have been thing.
Yes, sir.
Second, a drug could have caused.
Yes, sir.
Drug could have caused.
Yes, sir. And also
Third,
he
you
had
think drug,
diarrhea.
CAM could have caused. Third, do you think he's got an infection?
Yes, sir.
Yes, very good. Because please remember, a cirrhotic patient may not always come with fever or leukocytosis.
Yes, sir.
And most of these people may have an infection. I think one of the missed opportunities in ACLF is missing an infection very early.
Yes.
Or missing an infection. So there are what are called the missed opportunities in treating ACLF. One is this thing is not picking up an infection. So you could still have an infection. So according to the EASL criteria, you need to say that according to the EASL criteria, this could be this thing. Does it fit in with the APASL criteria, this ACLF?
Sir,
You would expect jaundice to be more because he had a bilirubin of 33. So according to APASL definition of ACLF,
according to APASL, it tells that any acute hepatic insult in the form of jaundice with bilirubin of more than 5.
What's the level of bilirubin?
With more than 5.
Correct.
Or
5.
INR of more than 1.5.
Very good. INR 1.5. With or without known chronic liver disease. He may have an underlying chronic which was not diagnosed, or he would have had a diagnosed chronic liver. So without
underlying diagnosed chronic
liver. Correct. So
or compensated.
Yeah. So the next question we would like to always ask you is, now there are three entities here. Can this be an acute liver failure?
Sir, acute liver failure, there is no hepatic encephalopathy here.
Good. So we need to know, so the question I would probably anticipate is differentiate acute liver failure, decompensated cirrhosis and ACLF. Okay.
Have a table on that.
Acute liver, decompensated cirrhosis and ACLF.
Yes.
So you show the crux 6, hepatic failure is present with encephalopathy will be present in
ACL.
ALF and ACL.
ACL. Yes.
But it's not necessary in decompensated.
Can there be a portal vein thrombosis in this patient? And that's always remember that as one component, no? Cirrhosis, decompensation. All these three always come together in all our patients. ALF, ACLF, acute on chronic liver disease per se decompensating, and the fourth is portal vein thrombosis. Only these four. In these four, put your priority. Which one will you consider? Number 1, 2, 3, and 4.
So learn what are the trigger points in APASL and EASL. In EASL, the trigger points will be infection, alcohol. APASL, it is hepatitis B reactivation and probably drugs, hepatitis E. That's what they don't include infections.
Yes.
They don't include infections. This one, though. Of course, you should know not consortium or anything where it is a very, very broad group. It does not have anything. It is just a 3-month mortality. That's what the NACSEAL group will say. So this one, kindly be very, very sure and go through that table of these things. Okay.
Yes.
So one can be acute and chronic liver failure.
Yes, sir.
It could be,
Alcoholic hepatitis.
or
Alcoholic hepatitis.
triggered by ACLF, triggered by alk hepatitis, or
Alcoholism.
or can. Can this be alcoholic hepatitis? Severe alcoholic. Yes,
Yes,
it's
sir.
possible.
It's
Severe alcoholic hepatitis also.
because the abstinence, the last intake was only 25 days back. So, according to definition, until 60 days, we can consider alcohol hepatitis.
Alcoholic hepatitis.
Yes.
Alcohol hepatitis can also come with ascites.
Yes.
Though
Due to
Central hyaline sclerosis.
sclerosis. Very good.
sclerosis, portal hypertension. At the same time, they might ask you, somebody who presents with alcoholic hepatitis, what is the percentage of them will be having cirrhosis
Underlying cirrhosis.
if you do a biopsy? So these questions they come up to you.
What percentage likely got?
What percentage now it is now being
Around 30%. 30, sir. 30%.
60% is what some of the group says. Okay.
Yes.
Our this thing, it was about 48% had cirrhotics. So around 30 to 60%, according to studies, will have cirrhotic. But I think it's always above 50%. I think 60% was the one of the groups from John Hopkins has said, and that be the thing. So these are the questions you can expect. So even though you say it's a prior alcoholic hepatitis, when you do a biopsy, nearly 30 to 50% can have cirrhotic liver. Okay.
Yes.
Okay. So you think it could be? Okay. You want to consider anything viral?
Yes, sir. I will consider underlying chronic liver disease etiologies. I will consider viral hepatitis also.
No. You think it could be alcohol liver disease, and the whole thing could have been triggered by a viral reaction. Hep B is one.
Yes, sir.
What are other two viruses which can really push him for an ACLF, especially in Indian context?
Hepatitis A and E.
Hepatitis E and A.
Yes.
Predominantly, we see more than E. It is, look at SK Acharya study, it is hepatitis B and E, which are the two most common things. Hepatitis A, almost 52 years, would have already had a developed antibodies by now. But
yes,
no harm we should think. Hepatitis A and B. Okay? So these are things which could happen. Other point, will you consider any malignancy like HCC? I think we should also keep it in mind. Yes. HCC, especially if this patient has got alcohol liver disease and a coexistent hepatitis C or anything, that infection. Probably this is one of them. But I think the first diagnosis agreed, the way he is presented will be ACLF. And alcoholic hepatitis, kindly remember, it is a manifestation of SIRS. It will be like patients are sick. They won't be stable. Patients are sick. They are tachypneic. They have got tachycardia. They will have fever. They will have they won't have small amount of ascites. Moderately big ascites.
Florid spiders, tender liver.
A lot of spiders. They will be tachypneic. All those things. So I always think that alcoholic hepatitis predominantly presents with systemic inflammatory response syndrome. Generally, they are. Yes or no? I think fair enough. Madam, you want to add on anything, ma'am?
No, I think that's fine. Yeah, I think HCC, you can go slow on that. You can
slow on
say that.
I think if they ask you,
but alcohol
as Madam
associated
said, portal vein thrombosis and HCC will keep in mind, but these are a little more dramatic. Somebody with HCC will not come with a mild ascites, you know. When somebody develops HCC, they decompensate well. They'll come with the ascites and rapidly go down. Okay.
Yes.
So if you shortlist, it will be alcohol-associated hepatitis, and ACLF will come as number one.
Cirrhosis of liver, probably.
Next will be alcohol-associated hepatitis.
Due to a trigger being alcohol, delay, and always, I think a subtle infection is always to be ruled out in any cirrhotic patients.
And patient also had diabetes.
All the students, patients come to your ER and who has got ascites, jaundice. I think 4 cultures and urine cultures should go from there because they don't present with fever, they don't present with leukocytosis. And the commonest infection, apart from Bargo, anybody can tell me what are the 3 commonest infections they can present to you?
Vanilla.
What are the 3 common infections they can?
spontaneous bacterial peritonitis,
Yeah.
urinary tract infection,
Hmm.
and cellulitis.
Cellulitis. Okay. So these are the things we should think. So okay, go ahead. Can we have the next slide?
Clinical examination. Patient is conscious, oriented, afebrile, icterus is present.
He
No
was deeply tricked. He was deeply tricked.
Yes.
He had a mild pedal edema.
Yes, sir.
And look at this, pulse is 86 per minute. BP is generally 110/80. Yeah.
BMI of 40 kilogram per meter.
Okay. Can I have the next slide?
Systemic examination, per abdomen.
Yeah, here, I don't know, I think abdomen is very soft. He had a mild free fluid was there. But he had a left lobe of the liver which was palpable and the right lobe was not palpable. Okay, the left lobe was much more enlarged than the right lobe. This is what my finding was. I don't know why they wrote organomegaly, free fluid. And he didn't have any encephalopathy. He is deeply tricked. He had a free fluid in the abdomen. We couldn't make out a spleen, and he had a left lobe which was firm in consistency. Right lobe was not really palpable. These are
in a patient who consume alcohol, I think very important. Carefully examine every system.
yeah.
Okay.
Carefully examine the liver.
Every system, respiratory system, may have tuberculosis. Okay, they may have basal crepitations. Then cardiovascular, they can have cardiomyopathy. CNS has to be done in detail, higher functions. Then you have to look at the millimeter score,
Starting from
do the figure connection test or do the number connection test, or at least ask him to sign, do a sensory system, gait, look for the motor system, every system, posterior column signs. You cannot go, you have to say cardiovascular system, first and second heart system, no murmur, cardiac size is normal, something like that. That means you've done a detailed examination. And in CNS examination, please see that you've seen the gait, you've seen the proximal muscle weakness, see that that every aspect of the examination is done in diabetics, chronic alcoholism, anything that is systemic, amyloidosis, all these systemic disorders. In one DNP exam in Coimbatore that I went, patient had dextrocardia. And the candidate went on speaking as liver and the right hypochondrium, everything. What should we do with a candidate like this? Just be attentive. Be attentive when you're doing the examination. And I would say don't start with abdomen. Then that's where you get lost. Start with, how do you write? You first say serious, respiration, then you do abdomen, then you do CNS, and then the skeletal system. Follow the same order. So automatically, your mind is not diverted towards the abdomen. Start with cardiovascular system. That means you're concentrating. Then go to the respiratory system. Then go to the abdomen. And then go to the CNS. And then to the skeleton. All the 4 systems you must do. The last will be the skin, 5th. So that you will not miss anything anywhere. But if you go straight to the abdomen, you would start thinking of the diagnosis, focusing on the abdomen, and you would have lost track of everything elsewhere. Recently, we had a case of truncus arteriosus, and left to right transposition. Murmur all over, and he's come with transaminitis. If I had not auscultated him first before going to the abdomen, I would have missed the diagnosis. Be very attentive. I just want to focus on this. Dextrocardia was missed by the candidate, by 2 candidates out of the 7 who appeared. Okay, and the candidate is describing liver is palpable in the right hypochondrium, and it goes on. So be very careful. These things do happen. When you're concentrating on a system, please concentrate while you're examining. Don't keep thinking of the case. That is what is important. Don't keep thinking of the case. Already you made a diagnosis in your history. You've already made it. Now you have to just see that other systems are normal. That's it. You understand? Varghese, good evening. Hi. We were waiting for you. Okay. Come.
Not bad. I think neurological examination here would include minimal hepatic encephalopathy, for overt encephalopathy, look for proximal myopathy, look for a sensory system, look for posterior columns. So very, very important. And gait, especially in alcohol liver disease, Has to be there. Some people are
And patients on steroids, autoimmune hepatitis, they'll be on steroids, and then you'll find that they have proximal muscle weakness. And for gastro, patients who are on ulcerative colitis, long-standing steroids, or bronchial asthma with steroids. What I want to just convey is one important thing. Don't keep thinking about the case all the time. What will be the diagnosis? Where will I go? You've already made a diagnosis clinically. History, 80% you'll be right. Only 20% you may go wrong with your findings. So then concentrate right from head to toe, all the systems in a methodical manner. This I want to stress to all the candidates. Start with the cardiovascular, then go to the respiratory, then go to the abdomen, then go to CNS, skeletal muscle, and then go to the skin, dermatology. All systems will be covered. Agree, Dr. BT? BT?
He is muted.
You're muted. BT, you're muted.
Yeah, I am listening. I am actually in Kashmir. I am in Kashmir.
Aha, enjoy. You're on the boat ride, huh?
Yeah, I am staying in the boat, but listening to your.
Enjoy. Okay, we continue. Come, we'll listen. Come on, move on. So, Bhargav, patient's got a liver that's enlarged in the epigastrium. Surface is smooth, tender, and look for HJR. Okay. Look for a palpable bruit. Bruit can be present in alcoholic hepatitis.
Alcoholic hepatitis. So, all those things.
Don't miss all that. Okay. No veins are present. Okay. Spleen is not enlarged.
There were no veins. Left lobe preferentially enlarged than the right lobe. Ascites, small spiders were there.
Spiders were there.
Spiders were there.
So do you think still this patient has got portal hypertension?
There are no any signs suggestive of portal hypertension. There are no any dilated veins, no
Does this patient have
splenomegaly.
portal hypertension? Yes or no?
Yes.
So what? Ascites is the patient portal hypertension, no?
Ascites could be a part of it.
Hypertension is part, no? Ascites is part of portal hypertension. Spleen may be enlarged. Don't fall into this trap. Spleen may be enlarged, not palpable.
Yes, ma'am.
Okay.
So cirrhosis, when it's compensated, decompensated, and decompensation is always driven by portal hypertension. So decompensation will be ascites,
veins,
jaundice, infection, and encephalopathy. These are complications, but what ascites is always driven by portal hypertension.
Can we move on?
Yeah, can we have
investigations?
So here, I think these are the diagnoses. Can we look at the investigations? So he was admitted on 8th. Forget about 12th.
Margo.
Okay. Hemoglobin 9.2, WBC count 80,400, neutrophil of 88.4%, MCV is normal, platelets 2.57, INR 1.5 and RBS of 1.
Relax. And before he came to us, he
macrocytic normochromic anemia, CRP is positive and 21.20.
No, 1 minute, Babu. Before he came over here, he had an ultrasound done in local, and they found that there was coarse ecotextual liver and moderate ascites. That's what, and that's why he came here, because his bilirubin was 33 here. So these are the investigations on. So he had a count of 18,400 and neutrophils of 88.4%. Okay. PTNR 1.5, RBS was 157, platelets were 2.57. Okay. Can we go to the next slide before we come back to this? Can you do on?
He's having.
Yeah. Just look at the LFT.
Total bilirubin is 21.9 with direct of 21.7. Yes, sir. AST is 132, ALT of 55. Total protein 6.2, albumin 2.1, globulin of 4.1. Gamma GD is 180, alkaline phosphatase 115, RP is normal, sodium is 127 with normal potassium.
Then urea.
Urea is 23.
There was some problem. Yeah. We are not able to hear you.
We are not able to hear. We can hear him.
Sir,
You're not able to hear, VK?
sir, urea is 23. Can you hear me, sir?
Yeah. Creatinine is 0.8 and sodium was 127. So can you
Yes, sir.
interpret? Prothrombin time he was anemic, MC was elevated. Prothrombin time is 1.5. Then
Yes. He had leukocytosis.
hyperbilirubinemia. He had leukocytosis.
Yes, sir.
Hyperbilirubinemia.
Yes, sir.
AST more than
Transaminase
AST
more than A.
AG reversal
Yes, sir.
and hyponatremia.
Yes, sir.
Okay, these are things what he had. For hyponatremia, actually, he didn't have any edema. He had only a moderate ascites. So what do you think could have been? He had a mild ascites. So what do you think?
Sir, hyponatremia in cirrhosis can be secondary due to infection also.
Yeah, it could be due to an infection. It could be due to, it should be some diuretic induced. So it could
Yes.
either be a dilutional, it could be depletion.
Dilution.
Or depletional. He had a mild ascites. He didn't have any fluid overload state. So but he has not taken any diuretics. This is how he came. Probably, I don't know whether he has had a low salt intake during the course of his camp. It is always common in camp to keep the salt away. These are few things which we thought. Why is it? So if you have always a low sodium, hyponatremia, how do you proceed to evaluate hyponatremia in a cirrhotic patient?
Sir, hyponatremia in cirrhosis most probably will be dilutional or dilutional will be around 70 to 80%.
Depletional or dilutional, isn't it? It can be depletion or dilutional.
Yes,
Only proceed to evaluate.
So what will be your test you will order? So
I will
clinically
order
you will see
for,
if the patient is fluid overloaded or
Urine.
he is
urine.
hypovolemic or urine. I'll ask for
Clinically you
urine
need to look whether it's
osmolality.
euvolemic or hypervolemic. Okay, number one. In urine, what do you want to ask for?
Urine, I'll ask urine osmolality and urine sodium.
Yeah, plasma osmolality, urine osmolality, and urine spot sodium.
Yes.
Spot sodium is less than 20. It is
Less than 20.
Yes, sir.
got hyponatremia as the low urinary spot sodium.
What is your interpretation?
Tubules are absorbing too much of it. So there is some sort of, it can be in a dilutional hyponatremia. If the urine spot sodium is less than 20 and if there is a renal injury, you think this could be HRS. If it is more than 20, this could just be AKI or it could be depletion. Yes. You would have used a diuretic induced also, it's a possibility. That is one thing. Okay?
Yes.
Okay. This is what I just want to ask you. But always, as you said, look for depletional, dilutional, and infections. Next. Next.
Viral serology, HBsAg anti-HCV negative, HIV negative, anti-HAV and HEV IgM, both are negative.
Ascitic fluid, we took it with a great difficulty. We took ascitic fluid. There was no SBP. It was a low protein, high SAG ascites. Okay, there was no SBP, no SAG ascites. Yes. And as I said, we sent all because he had a leukocytosis. What do you like to do?
Cultures.
Send all the cultures.
Yes, sir.
Send all the cultures. Okay. Send the blood culture. We sent
Urine
two
culture.
blood cultures and one urine culture because he had a leukocytosis also. Okay, leukocytosis here could be due to infection or it could be due to ALK hepatitis. Could be
Yes.
ALK hepatitis. So here all the
Are you surprised by the normal platelet count? Platelet count was 2.54.
Yes, ma'am. He was having 2.57 lakhs.
So what's your comment on that? Because you said cirrhosis without hypertension.
Ma'am, in acute infection, it can be acute phase reactant also. Thrombocytosis can be there. So it can be
So that's one
masking
possibility.
underlying thrombocytopenia.
At that point of time. Okay.
okay.
Next, what investigation you want? So astic fluid said. Next slide. Next slide, Harish.
There is no SBP, high SAG, low proteinuritis. The ADA
What's
also.
that?
Okay.
M55, monocytes 55.
Yeah, spot this. Monocytes 55.
Okay. Okay.
Ravi,
ADA
some
no.
mesothelial cells.
Mesothelial, no?
Mesothelial cells.
Okay. Okay. So there's no SBP. Okay. Next investigation.
If you see so much of mesothelial cells in ascites, say a patient has got, what is the negative thing it can give you? Very severe mesothelial reaction is never tuberculosis. Okay. In tuberculosis, you don't get so much of mesothelial cells. Classically, if you look at all the tuberculosis, it will be 95% lymphocytes and 5% neutrophils. So our pulmonologists, our TVs will say mesothelial thing is never tuberculosis. Okay, that's one.
This serum ferritin is more than 2000. With serum iron of 91. TIBC is 100. Total iron binding capacity is 9.47. Vitamin B12 is more than 2000. Anemia work.
Yeah. Can we go up next?
Hyponatremia evaluation. Serum cortisol is 33.05, normal. Serum osmolality is 257. Urine PCR is 0.4. Spot sodium of 5.24.
5
Urine osmolality 200. TSH is 4.2. Lipid profile is normal. So there are no any secondary causes for hyponatremia in this case.
Yeah, there was no cortisol was normal.
Yes.
And the thyroid was normal.
Normal.
This is something which we routinely say if you don't have too much of overload or something. Okay.
Yes. Yes.
And urine PCR is something which I check very, very often, especially alcohol liver disease and NASH related liver disease. Most of these people are diabetic.
Yes.
So I think I always check a urine PCR in these patients.
Yes.
So only thing the urine spots, that means sodium is already absorbed in the tubules. So that means probably it is something like a pre-renal, it may be leading on, going on to HRS or something. Okay.
Yes.
Okay.
Next investigation.
UST.
No, next. Go on, please. Go on. Next.
Cultures.
Next. We'll come back to this later. Can you go back? Next slide. Yeah, ultrasound abdomen showed chronic parenchymal surface nodularity. Portal vein was 13 millimeters. Splenomegaly was there by ultrasound. Mild to moderate ascites. This is what the present. There is no focal SOL or something like that. Okay.
Yes, sir.
We went ahead and did a CT because the bilirubin was going up. Endoscopy.
Can tell us the report. That's
You can just see some esophageal was a grade 1. There was a mild portal hypertensive gastropathy. Okay.
Yes, sir. So, CECT abdomen, the first one is I think plain, and the second one is either portal or venous. Data.
What does it show?
Sir,
What does it show?
sir, it shows liver is enlarged in size. Mild surface nodularity can be seen.
Good.
And
We don't get any
widening of interlobar fissures.
Hepatic veins are normal.
Yes,
Okay.
yes, sir.
There's a mild portal hypertrophy. Portal vein is that. Okay. We don't have any SOL or something. So the mild surface nodal disease. So they put it as a chronic parenchymal liver disease with mild portal hypertension. Okay.
Yes.
The dilated portal vein. That's what they said. Now, so this patient was in the ward. We were waiting for the cultures. He was admitted on 8th. 8th was what day? Yeah, 8th. So on 10th morning, 10th or 10th morning. So he was, so at this point of time, what will be your management of this patient after seeing these reports? So he's got chronic liver disease. He's got all the viral serology negative. We have no culture reports. He's got mild to moderate ascites. He's got a hyponatremia. He's got a low sodium in the urine. And he has bilirubin. PTINR is blocked. He doesn't have any encephalopathy.
Yes, sir.
So what will so in the ward? What will be your? Can you just outline the management starting from nutrition?
Yeah, outline the
for this management.
Outline the issues and start off with the management.
Sir, main management. I'll start with nutritional management. Nutritional management. In this case, hyponatremia that is there looks like depletional. So whether fluid restriction, not sure.
You can always give a challenge and see, number one.
Yes, sir.
We don't know whether it was given some diuretic by other doctors because he didn't have any prescription.
Yes, sir.
Okay, number one. So you can do it challenge and see, right? Number one.
We can see the IVC diameter through portal Doppler and can assess whether it is
echo is normal.
Okay.
So you will correct hypo. You will start with the nutrition. Can you tell me the nutrition?
So nutrition in this case, I will start with 35 kilocalories per kg per day of carbohydrates and proteins of 1.5 gram per kg per day.
1.2.
He is not able to take orally.
Sir, in case a patient is not tolerating oral feeds, then I will...
Not only not tolerating, these people always be anorectic, especially alcohol liver disease. They will not be able to eat, and especially if they have a trigger for alcohol, they will not be able to. What is the other way you can enhance this nutrition?
Enteral nutrition.
Enteral nutrition. Okay. There are any studies on enteral nutrition?
Yes, sir. There are some studies.
Nutrition combining with?
Enteral nutrition combining branch chain amino acids.
With steroids. And enteral nutrition combining with N-acetylcysteine. Just look at those two studies which have said nutrition. So one you're not able to do, you can go on with other enteral nutrition. Okay? Good.
Yes, sir.
So
either as a continuous drip.
it is always continuous drip.
Yes.
Don't give any much of a bolus drip. When you give a bolus drip, what can happen?
There will be rebound hyperglycemia.
No. Symptomatically, patient will have bloating and abdominal pain. When you put a bolus, the intestine is not used to receive such high osmolar quantity at that point of time. Okay. So you might get bloating, you might get vomiting, do anything. So you can always give a trickle of feed always. 20 ml, 30 ml per hour or 40 ml. Slowly you trickle a feed. If you know, previously madam will tell us that we used to have a chart when you have a feeding jejunostomy. In a feeding jejunostomy, remember madam, there will be one chart where first day you give 30 ml per hour, second day you give 50 ml per hour. Then you calculate the gastric residue and then you adjust it. Same way you have to do that. So you need to slowly increase it, trickle a feed. Okay?
Yes, sir.
That is one thing. Nutrition. Yeah.
Next, move on.
Specific treatment. Would you like to use antibiotics?
Sir,
Would
after
you like to
taking
use
cultures,
antibiotics?
I would like to start him on empirical
E. coli was
antibiotics,
positive.
Yeah.
covering
Always.
both gram positive.
Yeah. Empirical.
Yes, sir. I will start on.
What will you start? Patient is in SRMC casualty. So
Sir,
he has come
I will
from
start on either. Yes, sir. Sir. Yes, sir. Sir, depending upon any previous hospital admission, I will try to start the IV antibiotic. In case of no any previous admission within 3 months, then I will like to start him on either third generation cephalosporin or piperacillin azobac. In case if it's there, then I will start on carbapenem.
So if he has not had anything, but somebody with 33 jaundice would have gone to some hospital, admitted or come. So if you think this is going to be a healthcare associated problem, you will start him on piperacillin tazobactam. But at the same time, geographically, you need to look at
Local
of MR of multi-drug resistant organisms. If you think in your hospital, patients have come that area with the multi, I think you need to escalate it to either PIPSO or then go on to okay. So it all depends on whether the patient is admitted in within 1 month of coming over to the thing. So decide on what it is.
Yes.
Okay, that is what one thing we should know. So antibiotics will give. Then any specific treatment?
Bilirubin is 33.
Bilirubin is 33, PTI, bilirubin is 20, PTI is 1.5. Your DF is?
Will be more than 32.
Bargo, calculate.
Sir, it will be 4.6 into PT of patient minus control.
4.6 into 5, 20 plus 21. 42 is the PT. Okay.
Yes. Yes.
Serum bilirubin plus PT, PTNR of the patient minus
patient minus control
into 4.6, isn't it?
Yes, sir.
Yeah. And with the 21 bilirubin, you will expect this MELD also to be pretty high.
Yes, sir.
Okay.
So he's coming.
So quickly tell me the how do you look at the severity of alcoholic hepatitis? What are the scores?
Sir, severity can be assessed with either Madris discriminant function.
Madris discriminant factor. Number 2.
MELD scoring.
MELD score. Number 3.
Glasgow alcohol hepatitis score.
Yeah, Glasgow hepatitis score. Then
And
these
there
are
is
3
one.
things.
Yes.
There is one.
University of Toronto scoring system and Beckley scoring system.
Yeah, that's what you can think. So you should know, but you should know about. So this is what you should think. So you will expect this to be so. So is there a role for steroids here?
Yes, sir.
Provided you have pulled out.
His Madris discriminant function is more than 32. Hence, the mortality 1 month mortality will be more than around 50%. So steroids will be
provided you have ruled out infections.
Yes, sir.
The steroids. Okay,
yes.
So provided you have to wait for the cultures and do it.
Yes.
So we'll take care of the nutrition. I would prefer NS-style cysteine infusion is also indicated if they are on enteral nutrition. Of course, we take care of the nutrition and we take care of the infections and provided and probably some anti-coma measure. This is what we will look into it. Hyponatremia in this patient, we will try to correct it and see whether it is getting corrected with saline challenge. Okay?
Yes.
This is what we do.
What about flex, Bhargav? Flex? Role of flex?
Ma'am, right now, as he's having cultures being positive, flex is contraindicated.
Yeah, that's
Lactose is one of
one
the
thing.
contraindications.
No. So this is what happened. So he was like this on 8th, 9th, and 10th, and 11th morning. He was found to be. Can we go back to the previous slides? Go back to the previous slides. Go back to slides. Oh, this is not on 11th. On 12th, this is on 11th. It should be 11th. 11th morning, he was found to be having. He was unconscious. He was on grade 3 to 4 encephalopathy. He had no bleed. He was acidotic. BP was 80 by 60. And look at these figures. What do you think?
HB is
HB
8.6.
has dropped. Yeah.
Total count went to 40,000 with
Yeah.
neutrophils of 90%, platelet 1.8 lakhs, INR is 1.8, and RBS is 60.
60. So what does he have?
So, his condition is worsening with
So
INR.
possibly he's got an infection. He's got possibly severe leukocytosis. His INR has worsened. Look at the sugar, 60.
Hypoglycemia.
Hypoglycemia has come because of probably worsening liver status.
Yes.
Albumin drop was okay, but look at the creatinine.
Yes, sir.
0.80 to 2.28. Okay.
Yes, sir.
So you think this is AKI stage 1 or stage 2 or stage 3?
Stage
Can
1.
anybody tell me, wait Marbar, can anybody tell me what is AKI stage 1?
Deepak?
Deepak, when do you say AKI stage 1?
Vinila?
If the creatinine has gone up from 0.8 to 1.1, if there is a 0.3 milligram rise of creatinine 48 hours, it becomes AKI stage 1. Why is it we want AKI stage 1, stage 2, stage 3? In AKI stage 1, we don't use vasoconstrictors. So here this patient has got an infection. And the infection has precipitated an AKI. But here, if your creatinine doubles up, then it becomes AKI stage 2. If the creatinine is more than 4, then it becomes stage 3. Where we will, so stage 2, we'll use vasoconstrictors or plus minus RRT. Stage 3, we go to RRT. It is very, very important that you look through these things. So it has doubled here. So it is AKI stage 2. Counts have gone up to 40,000. He is hypotensive. He is in grade 3 to 4 encephalopathy. Lactate have gone up to 5.6. Sodium has dropped to 125. So what is the syndrome he has now? What is that? Bhargav? So he has developed encephalopathy. He possibly had a severe sepsis.
Yes, sir.
Then
Coagulopathy is that circulatory.
coagulopathy person. So he has got into ACL. He is in encephalopathy. He was in grade 3 encephalopathy. He had hypotension. His creatinine has worsened. So from ACLF, no organ failure. He has gone into what grade is this now?
Grade 3.
Good, very good. Grade 3. So he's got 3 organ failure. So he's got a cerebral failure. He's got a renal failure, and he's got a circulatory shock.
Yes.
Okay, now, so what do you do now? So we have sent all the again cultures. So now culture, all the 4 cultures grew E. coli. And prior to that, the first urine culture we sent was E. coli. This is where I said patient was looking absolutely stable with a count of 18,600. And before you can get the first culture, he has become septic, and this is what happens. So this is one of the missed opportunities of ACLF. That's why they die very, very fast. Okay, now Bhargav, so you know naturally you will shift him to a multidisciplinary place. Okay.
Yes.
So now what will you do now? Grade 3, grade 4 encephalopathy. So what do you do once he reaches ICU? He has got a BP of 70/60. Urine output has dropped to 10 ml per hour.
Yes, sir.
Creatinine 2.28.
Yes, sir. Sir, as there is low GCS,
Now, what has happened is this
I
culture came today, but the moment he went in, we changed the antibiotic. From Pipso, what do?
I'll escalate to carbapenem.
Most of these are called
And
yeah, we should go to carbapenem and probably give a gram-positive also. So you change out in minopenem and ticoplanin as one. Now, how do we treat his hypotension?
coverage and along antifungal also.
Noradrenaline support. Yeah, you can add probably an antifungal. Yes, agreed. You can add an antifungal.
Yes, sir.
Then how do we manage his hypotension?
Instead of giving fluid challenge and
Yeah, fluid challenge. You give. Okay, we gave.
I know. Noradrenaline.
How do you give?
First.
How do you give?
First.
How do you give NORAD?
How much NORAD you'll give? How do you give NORAD in these patients? You need to start at 0.5 ml and build up every 4 hours. Go up to 3 ml per hour.
Yeah.
Along with that, if it is not picking up beyond a fluid challenge, what are the other things you can do? You can give vasopressin. And is there any role of albumin in this?
Yes.
Which albumin? 5% or 20%?
5% albumin, sir.
5% albumin, you can go continuously at 5% albumin. And what is the role of albumin, Dr. Binila? How does albumin help?
It's a volume expander as well as reduce the inflammation, systemic inflammation.
Here the volume will generally be okay. What has caused this hypotension in this patient? Severe vasodilatation.
Sepsis and basically.
Severe low peripheral resistance. So you can't give volume expander. Creatinine is 2.28. He's putting out only 10 ml of urine. So you give NORAD plus you can give albumin. You can give 5% 250 ml. We sometimes give at 30 ml per hour and keep it going. You give a fluid challenge and give NORAD and vasopressin. So your targets will be a map of
70.
65 to 70 will be your map. And you should make sure that the map, keep increasing the NORAD till the map goes up by how many mm per mercury per hour. Very, very important in critical care hepatology. So you need to target. So at least 10 millimeters per mercury of MAP should go on every hour. There should be an increase of 10 millimeters of mercury of MAP every hour till you reach a MAP of more than 45%. 5% 250 ml of albumin is not what is being recommended because you can give an infusion, continuous
Larger volume.
brain infusion or that volume. That is what you can see. 20%, 100 ml only we can give that. That's what they say. And that is what you do. So, and regarding the kidney, you're giving NORAD, you're maintaining a MAP. If you are, you have given a fluid challenge. If your urine output is not increasing, what can we do?
Bhargav.
Totally.
Bhargav?
Ma'am, we can monitor
Should initiate early
ABG analysis
early RR.
if worsening metabolic acidosis or he's going replacement.
I think no, but I tell you, we need to initiate a little early
In
RR.
this case, SLED or CRRT will be better than hormone.
Yeah, correct. SLED or CRRT. Okay. And of course,
Yes.
for the encephalopathy, you should always do a CT to make sure there is no bleed inside. Okay, that's important once he stabilizes. And of course, the anti-coma measures will continue.
Features of cerebral edema.
So this patient, So then what else? If he's in grade 3, grade 4, how do you take care of the respiration? Intubate him.
Hi.
If it is grade 3, grade 4, intubate him. So grade 3, grade 4, and intubate. Okay. Make sure there's no bleed. Can we give, you need to continue enteral nutrition unless the patient is in severe shock. If he's in severe shock, we don't give enteral nutrition. And this. So this patient grew E. coli in all the 4 blood cultures, urine culture E. coli. So he was started on meropenem and targocid. He was given NORAD and vasopressin. And the moment the vasopressin was off, we started him on terlipressin. So the urine output went up slowly from 15 ml per hour to 60 ml today. He has become conscious, extubated, and his procal, which was 30, has come down to 4. Okay, so
Yes.
so this is what I'm trying to tell you. So this is what will be the management of this thing.
Would you consider liver transplant at any point of time, Bhargav? And the role of Plex. Discuss both this.
Ma'am, in case of ACLF grade 3, liver transplant
Can be done. Even up to ACLF 3, you can do a liver transplant. But your window period is very, very short. Within 7 days, you have to make an appointment.
Yes.
What is the mortality of ACLF?
So based upon his grades,
No, supposing grade 3.
grade 3 it will be around 70%.
So you need to think of a liver transplant. ACLF, you can do a liver transplant. You should discuss with the relatives. Number 1. 1 year survival in ACLF of transplant is
40 to 50.
70%.
80, almost 80 to 85. They say it's almost similar to any other transplant.
Yeah,
And recidivism they describe is very, very low.
In
It is not-
ACLF, there are few things. You will put them on RRT provided you bridge them to a transplant.
Yeah.
Number 1.
Very important.
Early RRT has to be done. You can't wait for too long to do it.
Only if you're planning for a transplant, not as a treatment procedure.
Third, in ACLF, you should also know the futility of a transplant. So what are the predictors of futility? When do you say that transplant will be futile in this particular patient? Severe hypotension, severe renal failure, patient on ventilator, and patient has got severe cardiac issues and severe extrahepatic infection. So this patient dramatically came out with the antibiotics. We gave albumin. So our strategy was intubated. First 24 hours, we didn't give him orally any enteral feed. Meropenem, targocid, and antifungal was started. And noradrenaline and vasopressin went on. Noradrenaline went up to 3 ml per hour. Vasopressin. By 24 hours, vasopressin stopped. We started terlipressin. Albumin was given 5% to at 30 ml per hour. And we kept the RRT ready, but he didn't require it. So once we took care of the infection, we can also. What is the role of PPI in this patient? Anybody else other than Bhargav? Deepak?
PPI, if
Never give PPI in cirrhotic patients. Why? Anybody else, please?
it will be, renal failure can be exaggerated.
It precipitates infections.
Infections.
Okay.
Achlorhydria.
Achlorhydria and bacterial transmission.
Bacterial dysbiosis.
Okay, it precipitates infections. That is what I think. So we had already told this patient for a transplant, but there was no futility because he think. So important things is how do we correct hypotension? How do we take care of infection? So this is an example where patient was relatively stable, and actually the urine culture Report came after 3 days. He was admitted on 8th night. By 11th, became the sick. We got the report saying urine culture was E. coli. So these are things in this case. Okay, supposing this patient was put on steroids. What would be the dosage of steroids you do?
1 mg per kg, 40 mg prednisolone.
For how many?
We will recalculate. We will calculate the Lilly score on 4th day and 7th day, and we will reassess the steroid response. And if it is Lilly score is more than 0.45, then we can stop the steroid. And if it is less than 0.45, we have to continue up to 28 days.
Supposing this patient clinically has become better, say his ascites has come down, but Lil score is above 0.6. Can you continue steroid based on any other score?
MELD
Yeah,
score, sir.
males.
Very good, very good. If your MELD has come down by 5, I think you can still continue steroids. Let us say on 17th day, he develops urinary tract infection. What do you do with steroids?
We will taper it off.
You can still continue steroids and cover him up with adequate antibiotics. The studies have shown that you can still give steroids despite infection. And by stopping steroid, it has not shown to improve the mortality or morbidity. So this, please look at the studies from John Hopkins. So I think this is a classical case of alcohol liver disease, underlying cirrhosis, hepatitis, Lilly, urinary tract infection at presentation. But by the time we could get the report and change over the antibiotics, he went into ACLF with a 3-organ failure triggered by a urosepsis and managed with he was extubated today and was shifted out, and then this is okay.
Good case, very good case. Yeah. I think it covered
Okay.
up all the complications. Yeah.
Now, what do we? And he was extubated, managed. Hypotension was managed with NORAD, vasopressin, terlipressin, albumin, antibiotics, nutrition, anti-coma measures. IC bleed has been ruled out by a CT brain. Now, today, creatinine has come down to 1.15.
Very good. Excellent.
What will be his chances of recovery, and why do you think we should consider a transplant?
Bhargav, answer, no?
Do you think we should consider a transplant? I'll ask him. Should I tell the family no, he'll become all right?
No, sir. We should consider him for transplant.
Another thing, especially. Supposing we have given steroids and he has had a little score of 0.16, 48, 4 weeks later, his bilirubin is 4.2.
Yes, sir.
You think his cirrhosis reversed?
What is recompensation?
What will be the rate of decompensation after improvement with steroids? How many will decompensate? 40% will decompensate. We may require still a
Transplant.
transplant. But sometimes, surprisingly, 60% of them may go on well for the next 5 years. So these are the statistics. Bhargav, kindly look into alcohol liver disease. Okay.
And de-addiction, no? You have to
And
give
then
it
the
that.
de-addiction program.
De-addiction. De-addiction, sarcopenia, and this thing we did not discuss. See that component is also assessed.
But I think it's more of a critical care hepatology.
That's what. So just see that everything is
And
covered.
what will be the missed opportunities in ACLF? This is what. So always avoid PPI. Number 2, always initiate investigations for infections. Recognize if it is a healthcare associated problem, give appropriate antibiotics in the emergency room. That is the most important thing. And recognize HRS AKI. You can't allow creatinine to go up to 2. If it is 0.6 and the next day it is 0.9, we check every day. And you think if it is going from 0.6 to 0.9, that means he is in AKI stage 1. So you need to initiate albumin in these patients. And these are all the things. And always, if you are not able to get fluid for SBP, kindly get an ultrasound guided SBP immediately, and you need to look at the result in 1 hour's time. What is the mortality if you delay 1 hour antibiotics in SBP?
20%.
If you delay 1 hour of antibiotic in an SBP, the mortality is 2%. So if you delay by 6 hours, that means it's a 12% mortality. So you should get this. So I tell my fellows that they have to get the bio. If not, put the thing and send it immediately. And your turnaround time is only 1 hour to get TC-DCM. That's what you should do. And because of very high risk of mortality in ACLF, always keep a transplant option open. And don't delay RRT. Don't delay him to become acidotic and all. Somebody was telling me he's not acidotic 4 hours. No. I think in the once the creatinine goes up, an AKI has got immediate mortality and a 4-week mortality. If a patient has got AKI, just when he recovers, then his mortality is still higher than a patient who did not have an AKI at the end of 4 weeks also. At 4 weeks, you can still have 28% mortality if you have even recovered from an AKI than a patient who never had an AKI. So it is important that you treat AKI very, very fast and put them on RRT or that. Madam was asking about Plex, Bhargav, in ACLF. Any idea about Plex in ACLF?
Short-term mortality is improved, but long-term.
Alcohol-associated
Madam,
hepatitis,
I can recollect any studies, madam. I don't
No,
recollect studies on Plex.
in CMC, they're using it for alcohol-related hepatitis, not for ACLF.
You can do a Plex with a small dose of
Yeah,
steroid.
because more of a
This is
surge
not a large
response.
volume thing.
Yeah.
And of course, the major
And in the
has come with
presence,
ALF, within ALF.
yeah, in the presence of infection, I think anyway it's contraindicated. So,
Infection is one reason why we want to do it.
yeah, and
But
hypertension is also there.
the best results of Plex in ACLF has come with HBV reactivation. HBV reactivation. So if you look at the Plex in ACLF papers, the best results have come with HBV reactivation. So recently we have one girl in the ward. Husband is HBsAg positive. She was found to be positive some time back during her first childhood. Then she now reactivated, came with enzymes of 1000. First day INR was 0.9. Fourth day INR was 2.1 with a flap. And HBV DNA was 83,000. The moment she went into ALF, we introduced Plex. We started on antivirals. And by third Plex, she recovered. So I think that is it. So the best ACLF has come with this thing.
Hepatitis B.
But in alcoholic hepatitis, I think in ACLF, more impact has been studied on the transplant. Early transplant, and you correct AKI with an RRT and bridge them to a transplant, or you do an early transplant at these patients. Okay? Or at the same time, you should also look at the futility of the transplant. Persistent hypotension, extrahepatic infection. If you have patient on a ventilator, and if patient is a diabetic, according to Paul Bruce criteria, diabetics also don't do well. If they're on a prolonged ventilation, then you may have to say it's a futility of a transplant.
Can we just move on to the 2 short cases?
Yeah.
Okay, Benila, you take this case.
A 59-year-old
1 minute.
male.
1 minute. I'll just tell you. I'll read it out. You have to finish off in 10 minutes. Dr. LBK, this input. So this is a patient who's admitted with us, I think just for 5 days back. Alcohol use disorder for 15 to 20 years, stopped in April 2021, and then presented with jaundice from August of 2021. And jaundice is progressive with occasional pale stool off and on. Okay. And however, for the past 2 weeks, that is first week of September, he had pain in the epigastrium and he noticed abdominal distension, and there was some history of fever. So I saw this patient yesterday in the ward, and he was tachypneic. He had tachycardia. Patient was sick. SpO2 was 91%. There were fine preps bilateral. And abdomen examination showed a hard, nodular, tender liver. Gallbladder was not palpable. Ascites was present. And there was no buoy, no rub. What do you think you're dealing with this patient? Jaundice for 1 year. Jaundice for 1 year. 2 weeks history of abdominal pain with fever and decompensation. And I've also given you the examination finding.
Ma'am, I feel it's a case of cholangitis, ma'am. And the Charcot triad is there.
Good. Yeah.
With the organ involvement, like respiratory as well as respiratory involvement, ma'am. So patient probably in cholangitis. The underlying etiology, since it's occasional pale stools, intermittent cholestasis. So
Good.
one possibility I'm thinking of is periambulary carcinoma, ma'am.
Very good. Yeah.
Then
Other possibilities. Remember the liver. The liver is
Periambulary
hard.
carcinoma. Okay, I do agree. You think it's cholangitis? Okay.
Hard,
Is alcohol liver
nodular,
disease a cholestatic disease?
Yeah, that's an important question. Is alcohol liver disease a cholestatic liver disease? Is it heterocellular or cholestatic or mixed?
it can alcohol itself can predispose to other malignancies, ma'am. I didn't get the
No,
question.
alcohol liver disease itself. If you have you looked at the biopsies of your patients with alcohol liver disease? They show cholestasis.
Yes, sir.
So it's a cholestatic disease.
Yes, sir.
And most of the times it is bilirubinostasis, You get
Yes, sir. Yes,
bilirubin
ma'am.
as 25, 30, but AST/ALT will be 85, 45, 55, So it's more for bilirubin, but it is a cholestatic jaundice.
Yes, ma'am. Yes.
Okay, this patient had also taken some alternative system of medicine. So what should you do next?
Ma'am,
Wait, don't show the reports now. What are your line of evaluation? What are just the important investigations that you would do in this patient?
complete hemogram, especially for total count,
Cholangitis, okay.
cholangitis, sepsis cultures, all the
Now,
cultures.
now you mentioned periambulary carcinoma. Look, jaundice is for 1 year. Jaundice is for 1 year. It is he has jaundice for 1 year, but in between there is some passage of pale stool. Do you think periambulary carcinoma will go on for 1 year?
Other possibilities are strictures.
And the liver is hard, nodular, and tender.
He may have underlying cirrhosis also, ma'am.
Yeah, underlying chronic liver disease. No? That's what Dr. NBK was telling, cholestatic jaundice. No? So he must be having an underlying cholestatic jaundice.
I might have an underlying chronic liver disease. He has
They're
been severe alcohol
predisposed
liver
to,
disease.
they're predisposed
So maybe
to
he had a
gallstone.
fluctuating jaundice going on.
They're predisposed to gallstones, they're predisposed to pancreatitis, so he may be having strictures, he may be having gallstones related to alcoholism, and that may be causing cholelithiasis and cholangitis. So have a wide perception of the case.
Okay, ma'am.
But when you examine the case, the liver was hard, it was nodular, but very tender. He could not allow us to touch the abdomen.
Liver abs.
So it could be a liver abscess. One is liver abscess, or I even thought, actually, when the presentation was being presented, I even thought of outflow tract obstruction. But it was nodular liver. So what are the investigators tell you? So you want CBC, number 1, number 2?
Liver function test,
Liver
ma'am.
function test. What do you expect?
Bilirubin, alkaline phosphatase,
No,
SGLT.
don't say bilirubin. Say you will expect direct hyperbilirubinemia.
Hyperbilirubinemia.
It will be around more than 15 or 17. He's severely pricked. Then number.
Moderate elevation of transaminases.
Then what levels of transaminases?
400, 300, 400.
In the presence of cholangitis,
Of alcohol. I don't expect that.
you will never get that high levels. You'll expect about 90, 100, 150, 200, 200, 240. And then what else?
Alkaline phosphatase and GGT, ma'am.
So what do you expect? Levels? See, it should not be, what I would like to stress is, you tell what you're expecting.
More than 1.5 times upper limit of normal, ma'am.
Yeah, more than 5 times. No? Then it tells you there is extra hepatic biliary. There is not more than 5 times, and it may be just cholestatic. Next slide. Next slide. Harish. Okay, so next slide. So just move on. Next slide. So WBC was 11,000. Platelet count was 2.8. INR was normal. Alkaline phosphatase 180. Gamma GT was 57. And ultrasound down outside showed mild IHBR dilatation and chest X-ray was normal. Next slide. Comment on the chest X-ray, the CT chest. He's a smoker. So he had this bronchiectatic changes. Okay, he had features of COPD. Okay, next slide. Comment on this now. We have 3 or 4
intrahepatic
CTs.
bare radical dilatation, ma'am.
For bilateral,
Liver is
unilateral.
bilateral, both lobes,
Hmm.
and liver is some surface irregularity with some nodularity, ma'am,
Surface
and mild
irregularity,
ascites.
minimal ascites. Next slide. Next slide. What phase is this?
Arterial phase, ma'am.
Why do you say arterial?
Aorta is prominent.
What else? What else is they seen in the liver which makes
What
you say
else?
it is arterial? The arteries are always thinner. So it supplies maximum oxygen but less of blood. No, that's the proportion. So you'll always see. Look at the arteries; they're all just small. So it is arterial phase. Next slide. Next slide. Now comment on this.
Gross IHBRD with dilated CBD. At the cutoff near the.
Okay, so what should you do now? So you have a patient here who has this, and this is a finding. So your and this ascites is present.
Okay.
Patient is very sick in the ward. This happened yesterday morning. What would you do? Patient is tachypneic. He's in the ward. He's SpO2. What should you do? What will be a line of management?
Should be started as early as possible.
What? Tell what antibiotic. No, you have to tell.
If there is no previous hospitalization, piperacillin tazobactam. Then if there is recent hospitalization, carbapenem.
Okay, then.
Then grade the cholangitis. If it is
this is your patient. This is your patient. Now just tell how to manage this patient.
It's look like grade 3, ma'am. He's having respiratory involvement.
No, what will you do, doctor? You've seen, you've said, you've discussed everything.
Drainage, emergency abdomen drainage.
Now the next question, how would you drain the system?
ERCP, ma'am.
Patient is tachypneic. Patient is in respiratory failure. Patient is almost, he's sinking, breathless.
Hypotension.
And platelet count was 28,000. Platelet count is 28,000. How will you manage? What will be a line of management? Deepak?
Patient has ascites, so percutaneous approach will be not feasible.
It's a very minimal ascites.
Yeah, though if
you think he will withstand an ERCP?
No, ma'am. General condition is not that.
What should you do? So, what are the options available
so,
for drainage?
Percutaneous biliary drainage, ma'am.
How would you do it?
And percutaneous retrograde biliary drainage.
LBK, just tell them the management.
No. Here, the options here is he's very sick. Platelets are low. So yeah, you can do a percutaneous drainage.
So we asked the hematologist. They said give an SDP. Okay.
Give a single donor.
Single donor platelet.
Yeah. Then do a
but then they said that will take 6 hours. Look at the problems that we faced, and they said we need at least 3 of them. Then they said you can do the random donor platelet. Okay. So we were stuck. What should be done? So what should you do? Patient is sick. He's sinking. He's in the bed. What should you do? You said percutaneous. So what would you do?
What percutaneous you will do? What is
it called? What is it called?
PTBD, man.
What is
PTBD?
Percutaneous?
Transhepatic biliary drainage.
Biliary drainage. And then what would you do? So we did a PTBD immediately. We didn't bother about the platelet. We just said we take a risk because the time was too short. Patient was also sinking.
Take a risk and then do one single puncture and get it.
Single puncture and then. Now what should you do? Today patient pulse rate is 80. Patient is stable. He's come out of it. And incidentally, when we palpated the abdomen, the liver is not palpable. Liver is normal in size. So what I want to convey is he had real hard liver. I had put my bet on that is probably an ampullary carcinoma with this thing. but still it is possible because there seems to be a pathology in the distal portion of the ampulla. So what should we do now? So today he's settled.
US or endoscopy.
Now what should you do tomorrow?
Now, endoscopic retrograde cholangiopancreatography to see the
So what's your aim? What should be your aim now?
to see the ampullary area and
Ampullary, yes.
CBD.
You can do a side viewing scopy and look at the ampullary area.
Ampullary area, and then try to
Another thing also you to rule out is you
Biopsy.
an alcoholic, you should rule out a chronic pancreatitis.
correct stricture. Yeah.
Sure.
And
And
then
you think that there is nothing by the side viewing scopy, you can do an endoscopic ultrasound to see if there's any the distal mass. Okay.
and try to
Because
internalize.
we still can't rule out a stone. He is too sick
Stone.
to think about it.
Yeah.
So I
And
think
and try to internalize. Always try to internalize. If you're not able to internalize, at least not a rendezvous, then at least place a guide wire and place a stent so that the bile is internalized and you can then withdraw the external. What are the complications related to the external biliary drainage? Any other options available? Supposing this is hilar cholangiocarcinoma, what is the other option available?
US guided cysto,
Hepatico-
hepatico
Hepatico-gastrostomy.
gastrostomy.
And then you can internalize. Okay. Okay. So this is just to tell you that this is a management. The jaundice is for 1 year, but the whole problem has started. Look at this. The jaundice is for 1 year, but the whole problem has started for the last 15 days. He's had a setback with all the complications. Frail, he's sarcopenic, and he did not manifest with high-grade fever with chills. He just said some fever. When we recorded the temperature is only 99. So this is called as allergy. That is when the patients are sarcopenic and malnourished, they don't mount an immune response. Yeah, they don't mount leukocytosis. It was only 7,800. They don't even mount the response to the WBC. So just read this aspect. When the platelet count is low, what will be the replacement? When will you replace? Is it a minimal invasive procedure? Is it a major invasive procedure? And what are the things that you would look for? Look at the dilated biliary system in this patient.
so. This patient has come with cholangitis.
Yeah, just ask
So
one
you
or two
think
questions.
this is predominantly will be a malignant or a benign problem?
Benign.
So if it is benign, what are the possibilities here?
Cholelocoligasisma,
Which is not seen here. What is the other possibility?
benign biliary stricture,
Due to alcohol for
chronic
might have
alcohol.
pancreatitis and a stricture. You can have an indeterminate stricture.
Yes.
Remember, malignant strictures do not present to you with cholangitis
Yes.
unless you have instrumented them or done a wrong procedure or not drained them well. Except some say periampullary can come with cholangitis. But if somebody has come with cholangitis, this could be a stone.
Stone. Yeah.
It could be biliary stricture which is benign, and this stricture could be because it's right up to the end. I think we need to look at the pancreas to see whether it's got any chronic pancreatitis.
He appeared to have something like a double duct, but we're not very certain. But anyway, ampulla has
Do a
to be
side
seen.
viewing scopy and see.
See.
I think the malnourishment, everything was due to probably pre-existing malnutrition
Alcohol.
due to alcohol liver disease,
Alcohol.
and this cholangitis would have still worsened, and he would have become frail or worsened his frailty.
Okay. Next case, move on.
Bhargav, when you're giving the diagnosis of a decompensation in the exam, kindly also mention about the patient is robust or frail.
Frail. Yeah. The sarco
Okay.
nutrition has to come in. Yeah.
That sarcopenic status, kindly
come.
mention whether he has got is easy frail or robust, and please keep a calculation of this frailty index somewhere. Okay.
Yeah, I've told him to read sarcopenia and frailty zone. Yeah.
Yeah. What is the chair raising test and all?
Yes.
Yes.
Deepak, last case. 63-year-old male, jaundice for 2 weeks, progressive, no pruritus, abdominal pain, preceded by low-grade fever and anorexia, no evidence of liver cell failure. This is the first time when he's come to the OP. Deeply icteric, laboratory feature shows a direct hyperbilirubinemia. AST ALT is 285, 345, alk-phos is 180, gamma GT is 52, albumin is 3.5. Viral markers, HEV, IgM was positive. All the other markers were negative. So the impression was that they're dealing with a viral hepatitis, just settling, and he was just managed with supportive normal diet. 15 days, everything seemed to be settling. and someone had done an MRCP and ultrasound outside, and that was normal. And however, 5 days back, just again 5 days from yesterday, 5 days just preceding this, he said the urine has become golden brown in color and eyes have deepened. What are the possibilities? In a patient who is HIV IgM positive, all of the markers written, no alcohol, nothing. When can you get a rebound of the joint? What are the causes?
Reinfection, ma'am. I mean, hepatitis, actually IgM. Hello. I cannot hear you.
Muted.
It can be reinfection by hepatitis A or E. Or this.
Ma'am, you are muted.
Ma'am,
E can have a reinfection, yes. Number one, it can be another virus, it can be an A, it may be even a reactivation of B. Okay,
yes, yes.
when else can you get this? And what are the other causes? Jaundice is settling and then it's coming back again. Again, waxing and waning. It could be just an obstruction. Okay.
Yeah,
Yeah, it could again be a stone disease.
Stone
It
disease.
be a stricture which has been missed by earlier people. We have been asking you a general question: what are the causes of recurrence of jaundice when things are settling down? So when can that happen? One is you've discussed viruses and parenchymal. What are the extrabiliary, extrahepatic causes that can present with recurrence of jaundice once it's settling? Again, polydipolithiasis. Yeah, polydipolithiasis, number one. Number two,
then
worms. There may be worms in
worm
the
infestation.
passage that is passing out. It can be just a stricture with edema. Any of these causes. Okay.
Yes.
So but during this time, when I examined him, second, that is just about 5 days back, he was deeply icteric again, and liver was palpable 4 centimeter below prostate margin, and there was a firm mass just below the underlying surface of the liver. But it was not globular, but it was irregular, but there was a firm mass just below. So what are the possibilities now?
Jaundice with a gallbladder palpable gallbladder suspected.
Mass. There's more like a mass. There's more like a mass.
Maybe a missed malignancy in prior imaging.
Malignancy of what?
It may be a periampullary carcinoma or cholangiocarcinoma distal.
Cholangiocarcinoma, distal cholangio? Is this the presentation? No.
There is no abdominal pain, so a gallbladder carcinoma will be less likely. And pancreatic
what percentage of patients with gallbladder mass or gallbladder cancer will have pain? 60%, 40% still not have pain.
Yeah.
Pain is, if it is there, it helps you. But if it's not there, it doesn't rule out the possibility. So how should we investigate? What should we do now? We had an ultrasound normal, we had an MRCP normal. What should we do?
Contrast CT of the abdomen will be better.
Okay, next slide. Next slide. Move on. Next slide. Comment.
Yeah. In first image, we can see the gallbladder fossa.
Just describe. Is it plain?
Is a axial image. See, this is a CT axial image. Shows the gallbladder wall irregular gallbladder wall. In the gallbladder fossa, there is a infiltration.
Infiltration or?
I think tumor. It's.
So you feel it may be a tumor, but how is it? No, it was not seen in an ultrasound.
Or maybe a rupture of gallbladder.
Perforation. So there could be a contained perforation. Because this was not seen in the just 2 weeks back. He said an ultrasound, gallbladder was normal. The MRCP, we saw the pictures. Everything seemed normal. Reporting was normal. We didn't have the pictures. What is seen in the second one on the right, upper right? What is that? Hypointense, hypodense, what is seen in the bed of the pancreas, close to pancreas? What is it? What is it?
It is
You think it's a stone? Possibly, no?
Stone.
Because it's
Yeah,
coming in the
possibly.
region of the CBD,
What is the
distal
region?
CBD.
Okay.
Okay, so what is now likely happening? What is happening?
It may be a choledocholithiasis with gallbladder perforation.
Yeah, it is a upstream dilatation with probably a blowout phenomenon resulting in. Mind you, patient is asymptomatic. Except for the jaundice, there's no fever, there's no pain. Patient is just walking around, he's going to the office and he's working. Next slide. Next slide. Now comment on this. Comment on the left first. The left. So
What is
what you see here? You see those two stones. See, look at the stones there.
Yeah, two stones you can see.
So it was actually a low insertion of the cystic duct and the CBD. There were multiple gallstones. There was low insertion of the cystic duct, and there were stones right up to the CBD. What should you do now? And the one on the right, you can see again the gallbladder fossa with a minimal peripolycystic fluid collection, suggestive of a possible contained perf. Okay.
Perforation.
Now, what should you do? How should you manage this patient?
We can manage with the IV antibiotic and
Patient
percutaneous.
no fever. Patient has no fever. Nothing. He's just comfortable sitting around.
Then endoscopic ERCP with biliary drainage and stone extraction.
And then?
And then cholecystomy or cholecystectomy after some days.
No, you have to decide what. No, you ask the surgical gastroenterologist. No.
Yeah. As the bed is still inflamed, we will go with the interval cholecystectomy with the antibiotic therapy for.
Yeah, if it's a perforation and this thing, and I think there is a very good thing. The other thing you can do is after you put a drain and remove the CBD stone, you can also do a percutaneous cholecystostomy for the time being and then do a cholecystectomy.
Yes.
That should be the way forward. Okay, next slide. So this is just the same picture, okay? Just to show you that multiple stones are there. Next slide, let's move on. Next slide. So video cannot be played, I think. You can show the next slide. So multiple stones were there, stacked stones in the entire CBD, which was missed on MRCP. Why I'm trying to present this case is be very careful in your history taking. In this particular patient, if you had said that this patient is a case of gallstone disease and choledocholithiasis obstructive jaundice, you would fail. Someone will give you a clue. This is gallstone disease with choledocholithiasis. Patient has no symptoms, no cholangitis, no fever, asymptomatic. So what will be your, if you had just seen the case as a first, it was HEV. I just said it is HEV infection. But when the patient came back with the second jaundice, I said, oh God, at that mass, I thought I had missed a periampillary carcinoma. I said, because it is coming within 2 weeks of the onset. And the gallbladder was palpable. And then retrospectively, when we look back, he had multiple gallstones. And I said, probably it's a stone that has slipped in. And then because of the low, now any precautions you will take for a low insertion, LVK just tell that, low insertion of cystic duct and ERCP. Can you just highlight on that importance, LVK?
Yeah, sometimes you can have a cystic duct stone slipping into the bile duct, or it could be an external compression. So I think, but I think there are plenty of choledocholithiasis. I think.
No, any precautions you will take while doing the procedure of ERCP in a low cystic duct insertion? Dr. Danesh did it. He said there was no problem. He just taught me. And
only other thing is the guide wire may keep slipping into the
cystic duct.
Cystic duct. So you need to push the sphincterotome up. Try to push it up and then bow the sphincterotome so the guide wire hits the bile duct wall and goes inside. That's what I think we just do it. If it's a low insertion.
What complication can occur during surgery of this patient?
Bile duct injuries can happen. Ischemic injury in immediate post-operative.
Why? Inadvertent ligation.
Yeah,
inadvertent ligation of the CBD, which they will be thinking as the cystic duct. As a cystic duct. Yeah. So that is very important. So last slide, let's move. Next. So I think a few things that we learned. 2 cases of obstructive jaundice. 1 patient presenting as large, tender liver, painful, behaving like malignancy. And even the CT people, they said heterogeneous. We're still not certain. It may still be an ampullary carcinoma. Only thing is the duration is 1 year. Underlying liver disease is likely. What I want to convey is just keep the patient in mind and keep discussing. Don't get carried away by the messages that you get across by the registrars who will be walking up and down and telling you that this is the diagnosis in this patient. Are you following what I want to convey? So these are some of the long-standing jaundice can be due to distal strictures, but then you get secondary biliary cirrhosis. But this time, this particular first case did not have secondary biliary cirrhosis. It was large, but some events took place much later. In sarcopenic, emaciated individuals, fever, pain, jaundice may not manifest. You may not get the chart puts right. You may not get the pentan, as Vanilla rightly mentioned. Heart, tender liver gave a clue that they're probably dealing with a so I thought it was a metastatic liver disease with cholangitis, ampullary carcinoma, alcohol use disorder, polystatic with gallstone disease. So I'm glad that Dr. LVK brought up that point. Polystasis is the feature. Only thing is, LVK, I think they don't present with pale stool and all, no? Except that biopsy shows polystasis, right? Right?
Yes, ma'am.
So it's more of a, so we see so many alcohol-related liver disease, but we don't get that, itching, pale stools and all that. But histologically, there is cholestasis, okay? And the second case, recurrent jaundice can have two etiologies. There's no symptoms of cholangitis, asymptomatic, except for hyperlipidemia. Next slide, last slide. So in the exam, have a column. The only question that they'll ask is it intrahepatic or extrahepatic? I've not written all the points, but if there is pain, there is fever, there's cholangitis, it's extrahepatic. But if it's absence, you cannot dismiss the possibility that it is not. Okay, in both the conditions, the liver will be large and smooth in all the benign conditions. If gallbladder is palpable, it is more likely to be extrahepatic. Okay, so when you're sitting outside and waiting for your viva and waiting for the presentation, have a column and see and keep on ticking. Okay, these points are there for my patient, so I'll put more towards extrahepatic rather than intrahepatic. See, both the cases that we presented, we were really not sure what we were dealing with. And only after investigation, we realized the spectrum of disease, spectrum of clinical presentation that these patients can present with. So it's a spectrum. Okay, we can just highlight this particular point, that they get carried away by this pain, fever, jaundice, and they keep hopping on that. So you can just give 1 or 2 points and then we'll conclude.
Yeah, the most important thing is that we need to have a second diagnosis in the same spectrum disease.
Yeah.
So we can present you with another probability. Number one. We'll always try to fit in everything into one diagnosis, but when the discussion comes, if you have an offer a second diagnosis also, you should be open-minded to it. And second, for heaven's sake, don't go with an open mind. My experience was that, see, if you get the clue, then you keep on trying to convince, trying to put in your findings into that diagnosis.
It's difficult. Very difficult.
So we had a 17-year-old patient who had features of Budd-Chiari. He had HCC, but the point is, at 17 years, you don't expect a HCC. Then our discussion went on into HVOT and portomesenteric thrombosis and etiology of that. What do you do? Then the discussion went off horry because they're trying to fit in that HCC in a 17-year-old. Then the diagnosis goes, how often you have seen HCC 70-year? Can it be this? Can it be that? Then it becomes a little unpleasant with the examiner that, okay, you got the clue and then you're trying to fit in. I think you just have to go with an open mind, and then you do much better when you're an open mind.
Because they assess, they accept. Yeah.
With an open mind,
yeah,
rather than knowing that and trying to fit in.
Yeah.
Then our interest to discuss the case goes away.
Yes.
Okay, so that is what I want to tell. This was my
very, very important. Very, very important.
As an examiner,
Yeah.
Trying to fit in after knowing the diagnosis is a bad thing, because the discussion can go off like anywhere, you would have thinking of alcohol, liver disease, but we could have just make everything about cholelithiasis and do it. So in that particular case, if it's a Budd-Chiari, then we were more interested what caused Budd-Chiari in 17 years. How do you manage? What do you do this? All that. So I think you should have a very open mind and see the case. I think you do much, much better when you're open mind.
And the best is after history taking, your diagnosis will be almost dot on 80%. Will be almost right because you have your intrahepatic causes, you have your extrahepatic causes.
And the questions we asked her, what do you do clinically every day in the ward? We're not going any out of the way and ask you something very exotic, no? Like I've discussed the case. On third day, he is found to be unconscious. He was tachypneic.
How you manage?
Hypotension. What do we do? Every day in London, we have to manage this. What we want to know.
Sure.
That's what I think.
Thank you, LBK, for the wonderful session, and thank you for taking us through. All the best to all of you. So we'll continue with the sessions until your dates are announced, okay?
They are taking the exam this year or next year?
Yeah. I think another 1 month they'll be through.
Another 1 month is theory, is it?
Theory results are out. Theory is over. Theory results are out. Yeah, D&D theory results are out. They're all waiting for the practicals.
Oh, practical.
So we are just increasing the timing as well as the number of sessions. So next week, Tuesday, they have a session. Thank you all and good night.
Thank
Thank
you,
you, ma'am.
sir.
Thank you.
Best wishes. Best wishes to all. Thanks,
Thank you.
LBK.
Thank you, ma'am.
for pitching